This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Good evening, everyone, and welcome back to our mini medical school on less is more, how less healthcare can sometimes result in better health. Tonight we will hear from Rebecca Smith-Beinman. Rebecca is a professor of radiology here at UCSF. She's also a professor of obstetrics and gynecology, epidemiology, biostatistics, and health policy. And Rebecca is really an international expert on using X-rays and other imaging modalities, how to make those most accurate, and importantly, how to ensure that they're as safe as they possibly can be for patients and also result in improved health. So she's going to talk tonight about a variety of imaging modalities and focus on using them properly and making them as safe as possible. Rebecca?
Thanks, Deb. Good evening. It's really a pleasure to get to speak to you today and to share some of the work we're doing at UCSF on this topic. How many people in the room have had an imaging test in the last year? Last year. How many have not? I mean, there's still opportunities this year to still get the imaging test, but we use a lot of imaging tests, and the improvements in imaging have really been nothing less than spectacular. So ultrasound, CT, MRI, PET scanning, they've been really amazing. And a lot of radiology research, both here and other places, really has focused on the development of new technologies. I call them toys, but I call them that affectionately. They're pretty magical. And many of them have had a very positive impact on health, and many people consider these advances in imaging to really be among the most important advances of imaging. I thought I'd spend just a minute telling you what I do personally, just to give you a sense of sort of my passion about imaging. I do ultrasound. That's my clinical area, 1 day a week. And give you an example of one way we use ultrasound. This is a very specific example, but just to give a flavor. Twin pregnancies are relatively common, and there's complications that can occur with twin pregnancies. And the one that I'm going to describe here is something called twin-twin transfusion syndrome. And what that is basically you have two twins that share a placenta, and there are lots of ways they can share a placenta, but one way of sharing the placenta, that's the blood flow, the source of nutrients, is called twin-twin transfusion syndrome, and it's a ominous situation. Fetal death occurs in up to 90% of these cases, and terrible neurologic outcomes. So it's a terrible thing to have. But using newly developed techniques, which use prenatal ultrasound, the test that I use on a regular basis, at a half dozen cases today where we use this, we can identify cases where intervention is possible. So sort of as a simple graphic and twin-twin transfusion, there are two twins, one's bigger, one's smaller, and they're not sharing the placental nutrients equally. This one got more than it needs, this one got less than it needs, and as I mentioned, it can be devastating. There are now ways to figure out using ultrasound to characterize these pregnancies, and only a minority of twin pregnancies have twin-twin transfusion. You don't want to do anything to the pregnancies that don't have that, but the pregnancies that do have that, if we can make the outcomes better, that would be really awesome. And we characterize the twins by the amount of fluid they have, by the blood flow, by the pattern of blood flow. And using this technology, we can identify the fetuses that need some kind of intervention. And for those cases, we do intraoperative procedure that basically takes this placenta that's not being shared equally and divides it in two. And the team includes pediatric surgeons, perinatology, and ultrasound working together. We look at the placenta, we see where the umbilical cords are, that determines who gets what blood flow, and then using ultrasound guidance, we make a small opening in the uterus. The surgeon puts in a laser device and separates the twins. So this is sort of the amniotic cavity inside the mom. We use ultrasound, characterize where these connections are. The surgeon uses photoscopy, and we basically separate these abnormal connections using laser. And the outcome of this procedure is really nothing short of miraculous. So the outcomes in these fetuses, I told you that up to 90% of fetuses will die after laser for the right fetuses. Almost 85% of pregnancies will have a good outcome. So this is one of sort of the most exciting parts of my job, and imaging is crucial and plays a huge role in this. So looking at diagnostic imaging more generally, I am a huge fan of diagnostic imaging, advanced imaging. Really, it's spectacular. And it turns out that I'm not the only one who's enamored with imaging. Everyone loves imaging, not for the case that I showed you, but for lots of different reasons. What we can do is really fantastic. And in part because we all like imaging so much, the use of imaging has really skyrocketed in the last 2 decades. It's gone up enormously. And this is driven by lots of factors, but 2 of those factors are doctors really like imaging. So the doctors who see patients want to get a lot of imaging on their patients to figure out what's going on. And patients really like imaging. It feels like you're getting your full health care when you get a fancy imaging test. But more imaging is not always better. Sometimes it's fabulous, sometimes it's not fabulous. And I think it's important to think about imaging the way we think about everything in healthcare, that it's a trade-off. There are some benefits and there's some harms. And that's true of imaging just like it is of medication or a surgical procedure. And in this talk, I want to highlight one of those harms that I think we need to think about to lead us to use imaging more judiciously. Just like we use imaging for really positive reasons, we sometimes use it for not so good reasons. And you got to think about that. And I want to put imaging into the same category as everything else we do in medicine. So my talk today is really going to focus on one potential harm to teach you about, and that's radiation exposure. And I'll talk about what tests deliver radiation exposure and what we know about its potential for causing harm. And then I'll go a little bit into some of the work we're doing at UCSF in this area and sort of what I'm hoping that you will gain from this talk to move forward in your own healthcare and the healthcare of your family. So just a little bit of background on what radiation is. Radiation is basically energy, high-speed particles and electromagnetic waves. There are many sources of radiation. Radiation is all around us. Some of it's naturally occurring. We get radiation from the sun. We get radiation that comes out of the earth, for example, in radon. We get radiation from food. So lots of naturally occurring, and then lots of other sources of radiation that are not naturally occurring. We use it in science, industry, and medicine. Included in that radiation is what's called ionizing radiation and non-ionizing radiation. Ionizing radiation is a subset of radiation where the effect on cells is well known. It's basically powerful radiation that can remove tightly bound electrons from their orbits. It can break chemical bonds, and it can change DNA. And depending on the dose, the impact on cells varies greatly. So at very high doses of radiation, you'll get burns, very acute injuries. At lower doses of radiation, you might not see the changes that occur, but you might be altering the DNA, and that subsequently can lead to problem. Ionizing radiation exposure cannot be eliminated, but the degree to which we can minimize the exposure, we have made decisions to do so. And there are many organizations, an entire alphabet soup of organizations, that have focused on minimizing our exposure to radiation. The International Council on Radiation Protection, the National Council on Radiation Protection, the International Atomic Energy Commission, both in the United States and abroad, to try to say, let's not eliminate radiation, but let's try to use it judiciously. In terms of medical imaging, most, not all, but most medical imaging tests use radiation. Ultrasound does not use ionizing radiation, and MRI does not use ionizing radiation. The rest of the tests that we do day in and day out, the tests that most of you had, use ionizing radiation. So the most numerically common tests that we do are just we call them x-rays, but in fact, all of these first three pictures are x-rays, but these are radiographs. This is a broken leg bone. You use x-rays to get this. Basically, x-rays are generated by a machine. The machine sends the x-rays through your body. There's a plate on the other side that collects those x-rays and generates a picture. So radiographs are x-rays. Fluoroscopy is also x-rays. Here you're swallowing something. This is bowel that's filled with contrast. This is an x-ray where you're injecting dye into the vessel. All of those use x-rays. The other kind of radiation we use, ionizing radiation, is in nuclear medicine called gamma rays. For gamma rays, the x-rays are not outside your body going across, but rather we put those gamma rays inside the body. You inhale them, you swallow them, you breathe them in, and then as that radiation comes out of the body, we take pictures of it that way. So those are the two basic groups of radiation, x-rays and gamma rays. Deb sort of described that I was going to be talking a lot about different tests, but the truth is I'm mostly going to be talking about one test. And the test I'm mostly going to be talking about are CT scans. And CT scans use x-rays, the same as those first three examples, but it's a really large contributor to our x-ray exposure. In fact, CT x-rays, it's basically a fancy x-ray machine that just keeps sending lots and lots of x-rays all around you and takes a circumferential picture, accounts for the dominant proportion of exposure we get from medical imaging. About 75% of all imaging exposure comes from CT scans. And there are two reasons for that. Well, several reasons. But first, we use CT scans really commonly. And the dose we use to get these, nothing short of spectacular pictures, it takes a lot more radiation to generate those pictures than to generate a simple radiograph. So this is a picture of a full body CT. This is a chest CT. So I don't have many questions on the slides for you, but I have, I think, one. So how many patients do we do CT scans a year in? So if we take, let's say, San Francisco, how many CTs on all patients would we be doing? And by a show of hands, do we do one CT per 5 people a year? One CT per 10 people a year? One CT per 100 patients per year? And one per 500 people a year? So I will say you guys did better on this question than most emergency department physicians who take this quiz. They always guess somewhere between 1 in 500 and 1 in 100. And emergency room physicians use a lot of imaging, but they're under the impression that other people don't. So to answer this question, we looked at imaging rates in the U.S. And for this study, we looked at patients enrolled in one of 6 large integrated healthcare systems. So one of the healthcare systems was one of the large Kaisers. And we looked at imaging over the last 15 years, and it was a lot of patients we studied, about 2 million HMO members each year that we studied for 15 years. And we were looking at how many tests we do in those patients. And this is a graph of the imaging we did over time. So on the y-axis, we have how many tests we did per 1,000 enrollees. And these enrollees are not sick patients. They're a combination of sick patients, healthy patients, patients who never went to the doctor, who went a lot, kind of a good cross-section. And at the beginning of the time period, 1996, each of these lines is a different healthcare system. We did about 50 CT scans per 1,000 people, about 5% of people. By the end of the period, we're close to 200 CTs per 1,000 people. So about 1 in 5 people are getting a CT scan every year. And the results have stabilized, but they haven't come down. So we're not using these tests only in very sick patients, patients who are in the intensive care unit, patients who are in a huge automobile accidents and need these tests. We're using these tests across a huge number of indications, and we're using them very commonly. So we're using CTs really often. What are the doses we use for a CT scan? And to answer that question, I get asked that question quite often. It depends on a lot of things. So first, it depends on what part of the body you're imaging. If you want to image the lungs, you don't need quite as much radiation as you might need to image the head, where you have to get through the skull, and it's a little bit harder to image. It depends how large or small the patient is. So if you're a really tiny patient, ideally you'd use a small amount of radiation. Where you have a really big person, you have to use more radiation. It depends on what the clinical question is that you're asking. Some questions are more complicated and you need to do more steps. But even though all of these factors are important, the last factor is actually by far the most important. It matters more where you go for imaging. Some people say which direction you point your car in, rather than what the clinical question is that you need to answer. And while all of these are really good reasons to have variation in the radiation dose, this one is not such a good reason for me. We should kind of know what the right dose is and use it. So I have collaborated on a large number of studies that have tried to figure out what the doses are for CT scan. And these studies were relatively uncommon in that we went to the scanners, we pulled out the data, and looked at what the doses were that patients actually received. So not what the radiologist wanted to do or thought they did, but actually go in, pull the data, and see what they did. And for all these studies that we have done, I'll show you a little bit of the data, we have found the doses for CT scan are high and highly variable, varying tremendously across institutions for patients who have the same clinical problem. So again, depending on where you go, the dose that you get varies enormously. So I'm showing you data here from a study we did in the San Francisco Bay Area. These are 4 different hospitals, Hospital A, B, C, and D. Effective dose is one of the measures of radiation dose. So by living in the United States, on average, we get about 3 millisieverts a year of radiation exposure, just by walking around and all the exposures that we get. For this study, we looked at patients, and we had over 1,000 patients in each of these groups. We looked at patients who went for head scans, I'll focus on that one, who went to one of our 4 hospitals with a suspected stroke. So they went in to the emergency department with symptoms that the emergency room physician thought was a stroke, and they got imaging. At this Hospital A, they got a dose of 18 millisievert on average. Hospital B, 15, Hospital C, 8, and Hospital D, 29. So a really big difference for groups of patients who are kind of similar. You thought they'd get the same dose, and we saw that for each of the clinical areas we looked at. And one of the things I think was very interesting is that no hospital had low doses for all of these types of studies. Some were low for one, others were low for another, or some were high for one and others were high for another. But every hospital had a chance to be high dose for some tests. In terms of why the dose varies, it's actually a complicated question because there are a lot of factors, but one of the factors is related to how detailed the images are. And in general, if you use higher radiation dose, the pictures tend to be prettier. So as radiologists, we like to look at more beautiful pictures. So actually, there was a second test. So this is a second test. How many people can see the pulmonary nodule in the image on the left? Raise your hand. Okay, as good as the radiologist. How about the image on the right? So this patient, I'm showing you an image from the chest part of the CT here, and you can see the nodule in both cases. And it's a little tricky to see, but these pictures are a little bit prettier. The lines are clearer, and it's a little easier to see the difference if we go to the abdomen images. So in the abdomen, this black is the fat in the abdomen, and it's crisper in these pictures. It's dirtier, grayer in this picture. So I would argue this picture is a prettier picture, equally diagnostic, but this patient had a dose of 1.5 millisieverts, and this patient had a dose of 15.9 millisieverts. And I'm describing this as if it's 2 different patients, but in fact, it's the same patient seen 1 year apart at the same institution. Happened not to be our institution, but we did a low-dose study here, and we did a high-dose study here, equally diagnostic in both cases, and yet 10 times the radiation dose. We didn't need the prettier picture for this indication, and yet we get the images. And I've shown this case to different groups of doctors, and when I show it to radiologists, they point out how diagnostic this picture is. And when I show it to internists, they ask why there are images through the abdomen, if the purpose of the study is to follow a nodule. And the sense of we should be looking around everywhere for everything, right? Look in the abdomen because it gives us more information is sort of one philosophy in medicine. And the other philosophy is let's just target what we need, and that will give us the information we want at the lowest harms, the lowest risk. Because in this case, the radiation dose is 10-fold higher. I'll show you another example of variation in radiation dose. This is not from a Bay Area example. This is from a national study we did called the STONE trial. The purpose of this trial was to figure out how to best image patients with suspected kidney stones. I'll tell you a little bit about more of this study later. But what I'm showing you here are the 15 hospital doses that we had in the study. So this is one hospital. This is another hospital. This happens to be our hospital at UCSF. This is the list of doses. This line in the middle, the blue, is the median dose that patients got at this hospital. So at Hospital O, the average dose that patients got at that hospital were 20 millisievert for this kind of CT. And at this hospital, our hospital, the average dose was about 5 millisievert. So the average dose was 4 times higher. And truth be told, everyone should have gotten a dose for the study that was at the red line at 4 millisieverts. So only 7% of patients got a low dose study. Everyone else got a high dose study, and it was profoundly different across these different hospitals. This is the variation that I think is really important to reduce. If we're going to do CT scans, let's at least make sure everyone gets those doses. So I think I'm going to tell you next about why I think this is, why I think you should be concerned about this issue, but just in summary, in terms of medical safety, the doses for CT scanning are higher than conventional x-rays. I didn't tell you how much higher, but if you compare it to a chest x-ray, so if a patient goes to the emergency department with a cough or difficulty breathing, a chest x-ray would be one dose, one. A chest CT would be a dose that's 500 or 1,000 times higher. If you compare it to getting dental x-rays, you'd have to get about 5,000 dental x-rays to be the same as one CT scan. And if you compare it to going through the airport scanners, you'd have to go through the backscatter scanners about 100,000 times to equal one CT scan. So to put it in perspective, these doses are much higher than the other doses that we've routinely seen in imaging, at least in decades past. So the question was how to put this in context of a mammogram. So a mammogram has a dose in the ballpark of about a half of a millisievert when the CT is about 20 millisieverts. So something like 20 to 50 times higher. Additionally, the use of CT has risen dramatically the last few decades. We're doing about 80 million CT scans a year in the US. This combination of higher dose per scan and more scans has resulted in about a 600% increase in medical radiation exposure in the last 2 decades. One of the issues that I'm very interested in focusing on, and I'll show you some of our work, is to bring the doses down, because the doses, quite frankly, are higher than needed for diagnosis and highly variable across institutions. And again, while higher doses can lead to more beautiful images, they're not necessarily more diagnostic. And the variation reflects physician practice much more than evidence. So what do we know about the carcinogenesis of radiation? Carcinogenesis means, does it cause cancer? And there has really been nothing studied more than radiation in terms of a carcinogenic exposure. It's one of the most comprehensively studied carcinogens, and there's extensive evidence linking exposure to ionizing radiation to the development of cancer. And these data come from a whole bunch of different sources. One of the most important sources of information is following the atomic bomb survivors. So obviously many people died in the A-bomb explosions, but people who didn't die have been followed in the many decades since then, and they're at increased risk of every kind of cancer imaginable, leukemia and every solid cancer. And they've been studied as a way to understand the harmful effects of radiation. But there are lots of other groups have also been studied. So patients who are treated for malignant disease, patients who have cancer, about half of patients in the US who are treated for cancer have radiation as part of that. And I'm not saying you shouldn't treat them for radiation. You should. You have a very short-term benefit. But if you're successful and follow them for decades, it turns out that there are many secondary cancers that are caused from the radiation, and provides a way for us to understand the potential harmful effects. We used to use radiation to treat many benign diseases in the 1920s, 30s, 40s, and 50s. Rashes, fungal infections, and those patients ended up getting radiation-related cancer in the area they were exposed. There are large groups of patients who we did repeated diagnostic x-rays on. So, for example, young girls with scoliosis, we used to do lots of films to follow the scoliosis, and those patients developed cancer. We followed mothers who were exposed in utero, and their children have gotten cancer. There are occupational, many papers describing the radiation exposures, and then environmental accidents, things like Chernobyl or radon. All of these have been studied. And when I say studied, there are thousands of publications. And there are two really beautiful reviews of this literature. One in the blue is a summary that was done in the United States. The one on the right, that was a review that was done in the UK, both led by a very esteemed team of scientists that basically looked at all of the data on radiation in the range that we're talking about for medical imaging to figure out what we know about the exposures. Each of these separate reviews reviewed, again, the large literature, and they looked at how risks vary by different factors. How old you are at exposure, a child has a different risk than an adult, the sex, and the dose levels, presumably to understand how the amount of radiation varies. Each of these reviews concluded that the doses we routinely use for CT will cause cancer in some patients. They're carcinogenic. And the higher the dose, the greater the risk. Thus, if we can bring doses down, the better. The risks are highest in children, and while the exact magnitude of the risk is a little tricky to quantify because of many factors, the elevation in risks is very clear. There's one study that I thought it was worth describing to you by itself, because this was the first study that didn't just look at ionizing radiation, but looked specifically at the risk of CT scanning. It was a recent study. It was published a couple of years ago, and this was the first one to directly look at CT. As part of the study, they followed about 175,000 children in the UK who underwent CT scans in the 80s and 90s up to 2002. In this group of children, there were 74 leukemias diagnosed and 135 brain cancers. And the authors looked at the relationship between what the dose was and the risk of cancer. And within 10 years of a CT scan, children who received doses in the 30 to 50 millisievert range, and these are doses that we have found 10 to 20% of children get on one CT scan, children exposed to this had a tripling of their risk of leukemia and brain cancer. Now, brain cancer and leukemia are relatively uncommon cancers, but a tripling is a pretty large effect from what we see occurs in a single CT scan. I mentioned it's complicated to assess the exact risks, and it's because different tests irradiate different parts of the body. You asked about mammography, that only radiates the breast. It doesn't radiate your liver, so your liver's not at risk. And different tests irradiate different parts of the body, and they use different kinds of radiation, the X-rays and gamma rays. And then for the same test, depending on where you go, the variation in dose is profound. It can be very low or very high. And then even if you know the exact radiation exposure that's used, depending on the patient, they will absorb different amounts of radiation. So size is a perfect example. If you have a tiny patient and a large patient who get the same amount of radiation, the impact on the tissues will be different. An example that I use, which I think is a decent analogy, is if you take a teaspoon of red dye and put it in a small pint of water or a gallon of water, it'll be very different dilutions in that pint or the gallon. And the dilution probably closely approximates the radiation-related harm. So one of the things we try to do is to tailor the dose to the size, but when understanding how harmful it is, you need to know exactly how large the patient was exposed. And so it is difficult to precisely quantify the risk. I get asked, what's the risk? A lot. It's very difficult to do. But in general, the higher the dose, the greater the risk, and we should at all times use the lowest dose possible. I mentioned that I was going to talk really about this one risk, radiation, and I wanted to digress on one slide to another potential harm of imaging, because it in fact comes around and also influences the radiation. And this is the area of false positives. These are, I think, best thought of as fake findings, which you don't know are fake until you figure out exactly what they are. And I think this example is very interesting. This was published in our leading radiology journal called Radiology. It was published as a letter to the editor by a chair of the Department of Radiology, Dr. Casarella, describing his own personal experience. And he basically underwent a CT scan as a screening test for colon cancer, CT colonography. He passed that test with flying colors. So he had no colon cancer, passed the test. It was great. But on that CT scan, he had several other findings that the radiologist noticed. There was a cyst, a mass in the kidney. It was a mass until they did another CT scan to learn that it wasn't a harmful mass. It was a benign cyst, which are very common. So he underwent another CT scan to look at the kidney. There was also a mass in the liver, and he had another CT scan to look at the mass in the liver. And that was inconclusive, so then he underwent a biopsy to see what it was, and it turned out that was that was a benign cyst in the liver. He had several pulmonary nodules. They didn't know what they were. He underwent a PET scan, also a test that has a lot of radiation. That was also not definitive, so he underwent surgery for those nodules, and that turned out to be infection. He lived in the South in an endemic area of histoplasmosis, a benign infection. So all of these things were raised on that initial test. They all seemed like they could be something, and all of them turned out really to be nothing. The cost was $50,000 to work these up. His recovery, at the time he wrote the letter, he was 5 weeks out of work and still not back to normal. In terms of diseases that were diagnosed, there were none. In terms of reassurance, we also often talk about how much reassurance we get from tests, and I completely agree that a negative test is wonderful. I did a couple of screening tests on myself last year. I had negative tests. I was really excited about them. But you don't always get negative tests. More often than not, you get these results, which are kind of negative after you've done 10 more tests to prove that. And there's a lot of stress before you clear up the disease that actually those tests caused. So I'm not saying he shouldn't have had a CT colonography. That's a topic that we can discuss separately. But by undergoing that, this all comes in that package. And the false positives are a real harm that comes with imaging. The costs are a real burden to our financial system. And then this led back to this patient having 5 times the radiation exposure than that initial scan. So just another potential harm to think about. So I think it's important for us to improve the effectiveness and the safety of the imaging we do. I don't want to throw out the baby with the bathwater. Imaging is incredible, and we need to use it and want to use it. We just have to realize that we have to use it judiciously. So in order to improve how we use imaging, we need to understand how we're using it, when we're using it, to quantify the risks, the benefits, and the outcomes. We need direct evidence of when to use imaging and when not to use imaging. When is more better, when is less better, and when to use imaging in a more effective, safer way. And it's really important that the kind of research that happens to guide imaging is collaborative if our goal is to really change practice. So we really want to bring together people who order tests, with people who perform the tests, with people who pay for the tests, and most importantly, for the patients who undergo the test to make sure their perspectives are included. And I'll acknowledge that there's definitely some tension within the radiology community about discussing this issue, about overuse and about discussing radiation dose, as imaging is really a very important and, quite frankly, very profitable piece of our healthcare spending. We spend about $100 billion a year related to medical imaging. And so we're reluctant to raise red flags and concerns. Nonetheless, from within the radiology community, there's really growing interest in figuring out how to use imaging more effectively and using it more wisely. So I was going to very briefly highlight just a few examples of the kind of projects that I think are important to focus on in imaging. Imaging research, as I mentioned earlier, has really focused on developing the technologies, but it's just important once we develop them to really figure out how to use them. Not just that they're theoretically great, but how they impact on our actual patients and their outcomes. So the 4 examples I was going to do is first an example of how you really have to focus on one clinical problem at a time. And I'm going to show you the results that I alluded to earlier from the STONE trial. Second, I want to describe in a slide a study that we're doing to really quantify the radiation-related harm from medical imaging, and that's studying the risk in children as part of the Radiation-Induced Cancer Project. The third example is how to do imaging more safely by reducing the radiation doses we used, and I'll explain results of the Partnership for Dose project that we're just beginning. And then lastly, our hope to engage patients as collaborators through an educational effort entitled Know Your Dose. So the first example, how to improve imaging one test at a time. Kidney stones are a very common reason patients go to the emergency department. There are about 1 million to 1.5 million ED visits a year in the United States with patients who go to the emergency department with suspected stones. It's extremely painful. It's the only disease I've heard that men get credit like childbirth in terms of pain. And so patients are going into the emergency department really in agony. And since the 1990s, CT scanning has become the primary test. So way back when we didn't really do very much testing, the urologist knew the diagnosis of stones based on the clinical presentation, or at least they thought they did, and we didn't really image very much. And over the last 2 decades, CT scan has become ubiquitous, and that's in part because it's so widely available. It didn't used to be so available. It's very easy to do a CT scan. It's available 24/7 in really almost every department in any city in the country, and this has led to almost universal adoption. However, despite what's been a 10-fold increase in CT scans over the last 20 years, there's been no demonstrated improvement in patient outcomes. Finding the stones, hospitalizations, finding other things, preventing complications. And so we've used this new test, but it's not clear that it's really been helping our patients. So the study that we did is called the Study of Tomography of Nephrolithiasis Evaluation, the STONE trial. It was a 15-center randomized pragmatic comparative effectiveness trial. And what that means is it had a really good study design. And we'd studied patients as they went to see their routine providers, not by having them do special things. We only did one special thing to the patients, which is when they came in, we assigned them randomly to either get an ultrasound by the emergency room physician, an ultrasound by a radiologist, or a CT by a radiologist. And then we let routine care happen. And then we followed the patients over the course of 6 months to find out what happened. So these are the centers that we did the study in. It was, they were all academic centers across the country. To be in our study, you had to be an adult patient. You couldn't be obese. You couldn't be very obese. You could be a little obese. You had to be at high risk for stones, meaning the emergency physician thought you had stones, and low risk for something else. And the emergency physician did a very good job. We have a lot of stones in the trial and very few alternative diagnoses in the trial. Overall, we enrolled just over 2,750 patients, and we included them in the analysis. And what we looked at in this trial are what I call outcomes measurements that really matter. So not necessarily finding a small stone, most stones pass on their own, but things that patients and doctors would really care about. So as an example, we care a lot about high-risk diagnosis with complications. So some patients in our study had acute appendicitis. Did we have any ruptured appendicitis because patients came into the study? Ultrasound is a less high-tech test than the CT, and I wanted to make sure that we weren't causing harm by missing important things. And so we had a long list of high-risk diagnosis with complications. We looked at radiation exposure, and we looked at costs, and then we had a large list of secondary outcomes, things like, did you leave the emergency department and come back and need to be admitted to the hospital? Did you come back to the emergency department? Did you have a serious adverse event that doctors thought was related to the trial? Your pain scores, was it different if you started with ultrasound or started with CT in terms of how resolution? Diagnostic accuracy was on the list. Did you find more stones? Although it was the one that I cared least about. I care about what happens to the patient, not so much did you make the diagnosis precisely or not. And we contacted patients a lot. By the end of the study, they were pretty tired of us, but we called them at 3 days, 7 days, 30, 90, and 180 days, and we reviewed all of their medical records from that hospital and the other hospitals in the city where they lived. So in terms of the results of this study, there were no differences in patients across the arms. So the same number were admitted to the hospital. That's sort of a test of a good trial is if you randomize patients appropriately. So there's same patients like this and this and this in all the groups were sort of similar. We didn't have sicker patients in one arm than in the other arm. So a randomized trial is very important scientifically if the groups are the same. If they're different, then you're not so sure you did a good job there. There were no differences in most outcomes across the arms. The high-risk diagnosis with complications were the same. So we had some high-risk diagnosis with complications. We had a handful with patients who had complications. We had a small bowel obstruction. The patient had to go to the emergency for emergency surgery. 2 days later, it was missed when they were ED. So we had several complications, but they didn't vary across the arms. They were exactly the same in the arms. All of these outcomes were exactly the same across the arms. And one of the tests of the study is whether ultrasound performed by emergency department physicians or radiologist physicians were the same. And in our trial, they were very similar. But there were two significant differences in our study. The first, the patients in the CT arm received twice as much radiation. Now, it wasn't infinitely more because some of the patients in the ultrasound arm ended up getting a CT scan. So they started with ultrasound, and then about a third of them went to CT scan. So some of those patients had CT as well. Yet despite the fact that a third of patients in ultrasound also had CT, the radiation dose was much higher in the CT arm, and the cost for patients in the CT arm, CT scanning is a more expensive test, were higher. So no improvements in the patient outcomes from CT, and higher costs and greater radiation exposure. So we concluded from this study that ultrasound should be the first test in patients who have suspected kidney stones. And it doesn't matter who has the expertise, being emergency room physicians or radiologists, whoever has the expertise in our trial did just fine in this study. This is important because sometimes, and in some EDs, radiology ultrasound is not as available as ED ultrasound is. So they call it point of care ultrasound, and it tends to be more available. And in our study, there was no difference. These results are being rapidly embraced by emergency physicians, and there are many reasons for this, but one of them is it allows them to make a really rapid diagnosis. They take the ultrasound probe, they put it on the patients, and they very quickly know what happens. And in our study, among patients who underwent an ultrasound by an ED doc or a radiologist, the patients left the emergency department sooner, an hour sooner, if the emergency department physician did the ultrasound, which makes sense. You'd have to send the patient out to another service and get the techs in. So it was, emergency room overcrowding is a very important issue in the U.S., and potentially this can reduce overcrowding if you make more rapid diagnosis. I want to point out that relying on accuracy, that means did we find the disease or not, is not enough to really demonstrate that a patient has done better. In our study, the accuracy was the same across the different arms, but partly that was because some patients got CT in the ultrasound arm. If you just look at just ultrasound and just CT, ultrasound doesn't do quite as well. And yet, not doing quite as well didn't result in any harms to patients. It means a few patients left the emergency department without knowing whether they had a stone or not, but they did fine clinically. And so finding disease earlier I feels very comforting. You know what's going on. You feel like you know what's going on. But that doesn't necessarily help improving your outcomes. So I mentioned I was going to tell you about a study that we're doing to try to quantify the harm of radiation. This is a study that's funded by the NCI, the National Cancer Institute, to study the risk of radiation in children and adolescents. It's a large study where we're looking at cumulative exposure to radiation and the risk of pediatric cancers. It's being done in 7 large integrated healthcare settings in the US and in Canada. We're studying children less than age 21 and pregnant women of all ages. And we're basically going to look at the amount of imaging that they went over time. Our sample size is about 50 million children, person years of follow-up. We're going to look at their imaging. We're going to do very detailed calculation of their radiation exposures that occurred in the 90s up to 2015, and then look at the risk of cancer up to 2017. This will be the largest and really more detailed study that's ever been done, and I think will provide really necessary quantification, which I told you has been difficult, of what's the risk in children of radiation. We're hoping very much to do a similar study in adults. We just have to find a few $1 million of funding to do that study. The next example is how to improve the performance of tests. So not focused on what's the harm or the benefit of the test, but how we do the test better. And I want to just review why the doses are so variable. I've told you the doses are highly variable, but why? And I think that's because there are no comprehensive standards or guidelines for CT scanning. You asked about a question about mammography, and I knew that number. And partly I knew that number because the FDA regulates mammography, and every facility in the country that does mammography has to fulfill certain standards and collect information. And one of those pieces of data are the radiation dose. That doesn't happen for CT scanning. There is no oversight of CT doses. There's no professional or government organization that's responsible for collecting or reporting dose information. Technologists who conduct CT examinations receive no consistent education across the country on how to do these exams or what doses are excessive. That's not the case in California. We have more stringent regulation in California, but the lack of consistent guidelines across the country is really mind-boggling. If you compare it to hairdressers who have certification in every U.S. state, you see the sign when you get your hair cut, they've been certified, we have less regulation for technologists who use radiation as part of medical imaging. We have a guiding principle in imaging, and that's ALAR, that the doses should be as low as reasonably achievable. And radiologists take this very seriously. We all believe that we need to keep the doses as low as achievable. But in the absence of explicit guidelines or standards for what's reasonable or what's achievable, each physician trying to develop their own standards is not a strategy, and that's resulted in the variation that we get. And so the practice variation is really the result of everyone doing what they think is the best, and that leads to, in my mind, excessive radiation. So in terms of how to standardize dose, which I think is imperative, manufacturers are developing solutions, hardware and software solutions, but it will take decades to replace the 10,000 CT scanners that are currently in operation in the U.S. And I think we need to really make more concerted efforts to improve the safety before these standards are, and these other solutions are available. And so we need to assess doses, we need to create benchmarks, what's the right dose, we need to develop strategies for meeting those benchmarks, and then we need to have incentives to incentivize everyone to meet those benchmarks. And those incentives are both at the policy level as well as by creating metrics that people can see themselves and compare themselves to. So I'll talk about two projects under this, the UC DOSE project and then a broader Partnership for Dose project. The UC DOSE project, the University of California Dose Optimization and Standardization Endeavor, is a collaboration across the 5 University of California medical centers, UC San Francisco, UC Davis, UC Irvine, UC San Diego, and UCLA. It's a collaboration of medical physicists, radiologists, technologists, biostatisticians, and our primary goal of this project was to pool data across the campuses and then use these data to describe and improve practice. We also submitted this grant because there's a law in California, it's actually the only law in the country on this topic, that requires radiation dose from CT scanning to be included in the radiology report. In my mind, a really fabulous law. And this was funded actually by the University of California Office of the President. So as part of this project, we pooled data across the 5 campuses. All the CT scans were sent to a central server at UCSF. And no surprise, we found considerable variation in the doses across the different hospitals. And while some of this variation that I described to you, you'd expect it to be varied by patient factors or scanner factors, much of the variation was not due to these factors, but rather the preferences for how we like to do CT at the different campuses. Personal preferences and independent interpretations of the literature of what's best without clear consensus or evidence. So to give you a flavor of what this looked like, this is a sample of data from head CTs, slightly different metric than I showed you earlier. This is CTDI vol. It gives you the sense of how much dose in one slice. At this UC, they had an average CTDI vol of 33. At this UC, they had an average dose of 62, about twice. So pretty big difference. As another example, this is doses in the chest. This is back to the effective dose. At this UC, the dose was 6, and at this UC, the dose was 17 on average. And these data are based on 50,000 scans in each of these cells. So it's not that they only looked at a few patients, it's that they use much higher doses at this institution for this part of the body than that institution does. So as part of this, we wanted to use these results to drive practice. And so we convened an in-person meeting and invited sort of the leadership for all the hospitals in these areas to participate. So we invited the head of neuroradiology, body radiology, chest radiology, technologists, physicists, researchers to participate. I was really floored by how cooperative and excited about the project that physicians were. For example, of the radiologists, there were 14 that were invited, separate from my research team. These were the clinical people invited, and 13 of the 14 came for our 2-day retreat to review what we had learned. So everyone was excited about sort of seeing if we could do something to get rid of some of this variation. Each site was provided with their doses ahead of time, and we had WebEx meetings before and after to review results. So there were no surprises at the meeting. Everyone knew what they were going to see. But basically, I asked the people to come prepared to either explain why they needed doses that were so much higher than other institutions, to defend their practice, or to change practice, to come open to learn about what other sites were doing. And we identified areas in several small breakout groups of where we could come up with common ground and really lower the doses. We weren't trying to fix everything, but can we agree that some areas we can all do the same way? And each group came up with concrete list of changes that we were going to implement, and then my research team really held them to those changes over the series of follow-up meetings over the weeks that followed. So these are sort of what the doses looked like ahead of time. These are data from 2014. Each of these is a different UC hospital. The dotted line is the summary. So this is looking at doses in the abdomen. And the doses were fairly constant. I could show you pictures before that showed they were fairly flat. So this is what the doses looked like. And then our meeting occurred right here. And then following the meeting, the doses in the abdomen basically came down at each of the 5 hospitals. And came down, when I talked to my biostatisticians, they came down the week after the meeting. You know, we have this period that we didn't count, and on the analysis I'm going to show you, the implementation period, you didn't need an implementation period. My biostatistician said they came down the next week after the meeting, which I think is quite exciting. So this is showing the numbers averaged in the, I think it's 3 months before the meeting, ignoring the meeting month, and then 3 months later. So at this UC, the doses went down. This is the average dose. Actually, they went down at every one of these hospitals. So before, from 15 to 12, 24 to 16. This is not looking so much at the average dose, but the patients who got high doses. So at this point, ahead of time, this group of patients had 37% of patients had high doses, and that went down to 23% of patients after the intervention. And the reductions occurred in all of the anatomic areas. Overall, a third, 32% reduction in effective dose, and 47% reduction in the doses exceeding the benchmarks. And then I had to pull the data from a different data source, but basically the doses have, in general, stayed relatively low in the follow-up period. So to expand on that study was really a pilot study to do it at UCs. We've expanded it in a project called the CT Dose Collaboration Partnership for Dose. This is a 5-year study. We're 1 year into the study. It includes academic hospitals like the UCs, but also non-academic medical centers in the US as well as abroad, and expands on our previous work. And it has, I haven't shown you so much, but we've published data on benchmarks. What's a good dose? And we're going to expand that to a much larger number of institutions. We're going to study the process of what works and what doesn't work. In the graph that I showed you, I conveniently showed you that the doses went down. I believe they went down because of what we did, but the design of the study It's not the ideal design. It could have been the doses were happened to be coming down at that point. Whereas this study, we're going to actually do a randomized trial, do different things to different places, and really study the process more completely. And we'll see what works and what doesn't work. We're going to do a lot of surveying of our institutions to learn about what they know about, what they care about, the institutional culture around making changes, quality improvement, to figure out sort of what's the right mix of things to help institutions do better. And this project funded by the National Cancer Institute and PCORI, the Patient-Centered Outcomes Research Institute. These are the institutions that are collaborating on this project. The UCs are serving sort of in an advisory role. These are some international hospitals, and these are U.S. centers. And these are not single centers. So the Center for Diagnostic Imaging has 35 imaging centers across the country that are all participating in the trial. So we have, all told, about 125 hospitals that we're trying to expand to see if we can bring down the doses. And then in the fourth and fifth year of the trial, we're going to try to expand that work to any hospital that wants to collaborate, basically to help them lower their doses. The current status of the project is we have a registry established at UCSF. CT radiation doses are flowing to the registry. We have over 1 million scans we've collected this year, and about 6,000 scans are added per day. We're finalizing the audit reports, which means the feedback we're giving to the sites on how to improve, where they're deficient, where they're doing a great job, where they should share best practices with other members of our collaboration. We're finalizing the expert teams that we're going to basically make available to all of these hospitals to help them. We're going to start working with sites in April of this year, and then hoping to create a publicly available website with what we've learned to share the experience. So the last example I wanted to give you of project is something that we've just gotten a very small grant for called Know Your Dose. And this is a new effort entirely focused on patients. It's funded by PCORI, the Patient-Centered Outcome Research Institute, a group that's particularly interested and concerned about patient perspectives. We plan as part of this project to speak to patients about imaging, to learn their perspectives more than I possibly could know at this point, their experiences, their questions and concerns by interviewing a large number of patients. Our goal for this project is to develop materials to help them understand imaging, the risks, the benefits of imaging, and the risks of imaging in terms of radiation dose. We'll create, as part of this project, a website targeted to patients that will expand information available to patients on imaging and to help make the best decision-making. This slide is really a plug for this project. If anyone's interested in getting involved in this project, I would welcome the opportunity to speak with you, have you speak to our research team, to really share your insights of how we could do a better job in explaining what we're doing and valuing your views on imaging. If anyone in the audience happens to want to learn more about radiation related issues from imaging, we created a large virtual meeting that's focused on imaging and CT scanning. The meeting is targeted really to healthcare professionals, radiologists, technologists, referring clinicians, and trainees. But there's a lot of really interesting information, and many patients have told me that they've learned a lot by going to this site. It's freely available, and as long as you are not spending 100 hours on the site, you can look through the offerings and really find a lot of meaningful material to very specific questions. So it looks a little bit like walking along the Mission Bay campus. This is the website. You can search it by virtual meeting and radiation safety. It feels like you go into the building and then there are lots of different areas to go and different activities to learn from. And there's a lot of lectures. There are 100 lectures from an incredibly distinguished group of faculty. We have a U.S. congressman who spoke. We have the head of the Agency for Healthcare Quality at the time speak. We have people from the CMS, many quality people, many physicians across a whole range of specialties. And some of it's very technical, key concepts in reducing dose for CT and how to optimize protocols, but it also talks about how to improve utilization, when to avoid imaging. The person who runs a national effort on helping patients choose wisely about imaging has given a really fabulous talk, understanding benefits and harms, the public health perspective. So if you're interested, there's a lot of material there. So is this important? There are many very important areas of healthcare. I am not in any way saying that this is the most important area. This is an area that I think it's worth putting attention to because we care about trying to make ourselves healthier. And there are very few carcinogens. We talk a lot about our exposures, about what we should eat and whether we should be in the sun, but there are very few things that we can really alter that change our cancer risk. For radiation exposure, the time to develop cancer is relatively short. It can be long, but it can be as short as 2 to 5 years. And the number of patients exposed is incredibly high. So the potential to reduce our exposure could have a real and meaningful impact on the number of cancers. It's estimated if we reduce the doses, get rid of those high doses, we can reduce the cancer burden in the ballpark of 2 to 5%. So just by lowering those high doses, we can have an impact. And then if we reduce the utilization, get rid of tests that are not necessary, we can reduce the exposures even further. So what can you do? First, understand that imaging is an important and often necessary part of medical care. So in my family, I've had a CT scan. 2 of my 3 children have had a CT scan. And they've had CT scans, and yet I avoided a CT scan, and both of those same children avoided a CT scan. So it was just sort of figuring out when it was appropriate and when it wasn't appropriate. And that comes about both for me as a parent and for you as patients and me as a researcher, is to understand that imaging is not a panacea. It comes with risks and benefits, and they have to be balanced, just like everything else we do in healthcare. I think we've been so excited by the technology in imaging that we forgot that it comes with trade-offs. And when you're going to undergo a test, figure out why. I mean, it seems like an obvious question, but if your doctor orders your test, ask why. What are we trying to learn about this test? Do I need this test? If I need this test, do I need this test now? Or can I have it later? If I need imaging, can I have a test that doesn't need radiation, if that's a choice? If it's not a choice, and that's sort of a mutual choice between you and your healthcare provider, then you act appropriately, but you need to ask. And I would say you don't want to go to interactions with physicians knowing that you want an imaging test, because you might and you might not, and you want to learn about what's the value of the test in any given situation. And if you're getting a test that uses radiation, like CT scan, I encourage everyone to ask about the doses. Ask your provider about the doses, to go to places that have low doses, to ask the technologist who's going to do the study to use a low dose technique, and ask the radiologist to use the lowest dose possible. We have protocols at institutions that say, use this if the patient asks for a low dose, which means you should ask for a low dose to be sure you get that whenever it's possible. And I will end here. If anyone has any interest in learning more, feel free to email me or any members of my team. We're all online, and we would welcome your questions, and you're getting involved in our studies in various capacities if you're interested. Thank you so much for the opportunity to share this presentation. So we have some time for questions, and I be happy to take some, one, two. So the question is, are there efforts at sort of a federal level to sort of create standards? I don't think I could have planted a better question in the audience than that one. So I personally believe that given the doses and the potential for harm, that there really should be oversight. It turns out the example I gave from mammography, where there is close oversight, is the only test where there is close oversight. And so I think it's always an uphill battle to put in place new regulations and oversight and figuring out how to pay for it. But I've personally been honored to testify before Congress on 2 occasions on the topic. And I've spoken at a lot of professional meetings and to the FDA. I very much believe that we need some standards and that organizations have to be held accountable. So I think one of the things that's lacking in having that oversight is a patient advocacy group that really cares about it. And it's very difficult to get oversight without that patient group that cares about it. In the absence of oversight, I'm involved in some efforts to create standards through the quality approach. So an organization called the National Quality Forum adopts measures of quality. and then their organizations that are part of them then adopt those measures of quality. So I've just submitted a measure on radiation dose in children to monitor doses. They've just adopted the measure to try to put much more concrete standards in place. So I completely agree with you that it would really improve health and safety if we had those standards. I believe they will be in play, but it will take years until we've adopted those standards. And yes. So the question is, how do all these different providers who take care of a patient, the ordering doctor, the doctor who's doing the test, the patient, how do they work together to make good judgments? I think the best way to have good decision-making is for the patient to really be very actively engaged in what's going on. So I don't want to pretend that we all see eye to eye, but more often than not, we do when we talk to each other. So I mentioned that I do clinical ultrasound. I talk to my providers every day about the patients that we see on the inpatient side and increasingly on the outpatient side. And I think the care is better when the referring doctor calls me and says, Rebecca, what test should we do now? Do we need a test? How do I interpret the results? And the best person to make that happen is the patient. And so I think sometimes patients go into an encounter wanting a test, and that's not always in their best interest. It's much better to go into an examination open. So I mentioned that a few of my kids had had CT scans. One of my children, a son, once fell out of a tree, and I happened not to be home, but he started vomiting at the kitchen table, then put his head down to go to sleep over dinner. My husband took him to the emergency department, and they did a CT scan, making sure he didn't have a bleed. And there wasn't a lot of discussion about should they or shouldn't they. On a different occasion, the other occasion, my husband wasn't home and it was just me. My son had a much more mild injury, but he kind of was acting off. It was a skiing fall. He didn't seem quite right. And I brought him to the emergency department myself, and the emergency room physician said, look, if you want a CT scan, I'll do it, but he's fine. He doesn't have a bleed. He might have a small concussion, but he's fine. And I said, no, I wanted your expert opinion, not my opinion. And I talked to my doctor, and our family talked to our doctor, at least in both of those cases. In one case, yes, imaging, one case, no imaging. And I think that's sort of the kind of dialogue that has to happen. The question is the age of the equipment important in the dose? So very old equipment, super old equipment, 20 years old equipment, probably needs to be replaced. And as part of one of the studies we did, one of the pieces of equipment at one of our centers was in fact 20 years old, and as a result of our study, they replaced that scanner. But in general, most scanners are not nearly that old. They get replaced, and they have the capability to be programmed to use lower doses. So most scanners need to be used appropriately and maximized. You don't need a brand new scanner. Now that being said, the brand new scanners that are 6 months old do have new features that make it a little bit easier to do lower dose. But most of the variation does not have to do with the type of scanner or the age of the scanner, but how the physicians choose to use it. We've just finished a paper that basically says that the manufacturer and model and year matters a little, not a lot. It's how it's used that has the biggest impact. So the question is, a patient perhaps can influence whether they have a test, but not how the test is performed. That sort of seems to be the job of the doctors and the technologists to ensure that. One of the funders of my work, the Patient-Centered Outcome Research Institute, is funding me to work with other doctors and other technologists and other medical physicists to standardize what we do. And yet if patients send the message that they care about this topic, it makes my job a lot easier to do, right? So if you don't care about this topic, I have a much harder time convincing radiologists, technologists, physicists that they should get additional education, follow my standards, where if I have patients who care about this issue, which is why I was really quite thrilled to speak to you as an audience, then you can say, I really care about this issue. I want to go to an institution that follows the National Quality Forum metric on radiation dose. I care about this issue enough that I'm going to choose an institution in part based on that. So the question is about MRI safety and whether there's potential for harm there based on the strength of the magnet. And the truth is I really don't know very much about MRI. The studies of the potential for harm have not been done, and I just don't really know the answer to that. So the question is, how do you know the radiation dose for an exam? So in the work that my group does, we do it two ways. First, we figure out the radiation that comes out of the machine, and that's relatively straightforward. The machines, modern machines, not older machines, will record very specific parameters about how the settings were done and a whole bunch of different factors, a half dozen factors that you can calculate how much radiation comes out of the machine. Then my lab gives those data to a mathematical modeler who basically creates these Monte Carlo models, which are basically probability models of if I do this experiment by putting this much radiation into a patient of this geometric configuration, which is based on their height and their weight and BMI, whichever of those I have, and estimates what the dose is to different organs of the body. And so for our study, for example, looking at cancer risk in children, we'll model the bone marrow dose. So in the exams that these children underwent, we'll pull the technical details out, we'll send it to my team in Florida that will give us organ doses, and then we'll look at the relationship between those organ doses and those organ cancer risks. And some of the work that we've done is relatively unique in that we go down to very granular levels of data to really understand the exposures and hopefully the risks. The question is sort of twofold. For an individual patient, can you ever know if the cancer came from the radiation? And the answer is no, right? In the US, 35 to 40% of people will get cancer over the course of a lifetime. And the cancers that come from medical imaging are the same as the other cancers. And there's no way for an individual patient to separate them. And so the way we study this is we use epidemiologic methods. We put a whole bunch of patients in one room who didn't have radiation. We put a whole bunch of patients in another room who did have radiation, and we see if there are differences in cancer after we account for other factors. And it's really very much what we do for smoking research, to know if smoking causes lung cancer. There are patients, unfortunately, who get lung cancer who never smoked. And so for an individual patient, it's always hard. It's just smoking is such a strong risk factor that we guess that most of it comes. But we use epidemiologic methods. We can't tell for an individual patient. We can tell in basic science models or mice models that if we radiate them, we will give them cancer. So those models exist. So in terms of the association, we study it with epidemiology, but you're absolutely right. It's more difficult to understand. And it's difficult to understand because what's going to happen is going to happen years down the road, 2, 5, 10 years. And by the time that occurs, it's hard to know for that patient what caused the cancer. So I think that's one of the reasons this topic is very difficult to explain to a lot of people because it takes a while to occur. So I need the test today and the harm doesn't occur for a few years down the road. It's a little tricky. One of the things that occurred that made this topic more accessible, more understandable, occurred in 2009. At the time I was publishing on this topic, there were a series of radiation overdoses for CT scanning that were not at the level that we were talking about today, routine studies. These were levels, these are regular levels. These levels were sort of up there. They were doses that patients got when they had a diagnostic CT scan where things really went awry. And the patients got a dose that was 100 times higher than I've told you today. And those patients ended up losing their hair in a band-like distribution. So days and weeks after the CT scan, there were patients who had this hair loss that was very visible. Now, they had other symptoms as well. They had cognitive problems. They couldn't think clearly. They couldn't focus. But the hair loss was very, very visible. And I think that was very important for raising awareness that the CT scans can deliver these high doses. But the the less visible changes, the broken strands of DNA that don't repair, that lead to cancer, are much harder to see and to quantify. So the question is, doesn't everyone want to reduce the radiation doses since we know it has the potential for causing harm? So I would say that question is, assumes that anyone's doing it on purpose. No one's using higher doses than needed on purpose. The images that I'm showing you are actually very complicated to obtain. If you look at a CT scanner console, there are a lot of buttons. It looks like the console of a fighter pilot's jet. It's not like you're pressing a low-dose button or a high-dose button. You have to make a lot of decisions. And we haven't done the best job of standardizing those decisions so that every time you're doing a particular study for a particular indication, you're coming up with standard processes for doing that. And every manufacturer is different, every machine is different. I think that's part of the problem. We want to standardize that, but no one's using excessive doses on purpose. It's rather, we haven't really been looking at this topic. We haven't been noticing the doses we use. Perhaps we need legislation to encourage people to do that. But I think we have become so enamored with imaging, we hadn't really thought about the price in terms of the radiation exposure until relatively recently. So I think I mentioned there is definite interest from within the radiology community to really improve this, to do a better job. And I just am encouraging us to do it faster. So the question is, do we have materials targeted to patients to help them understand what's the right test to use in different settings? And I think that's an awesome question. I think we need to develop those tools. I think we need to develop those tools for patients and, quite frankly, for referring physicians to help guide imaging. I mentioned this Choosing Wisely campaign. It's organized by a group called the American Board of Internal Medicine Foundation. And it was started, I believe, to really help raise awareness within the medical community, but also to patients, that you have to make wise decisions about testing, about lab testing, about imaging. And I don't know how many organizations, how many professional societies this effort started with, but now I think they're up to about 75. So the American College of Radiology participates in this effort, the American College of Cardiology, the American College of Family Medicine. And each organization, the way it's organized, came up with 5 tests that their society does that we don't really need to do as often. And they have phenomenal materials for patients. So these are common tests that are done that maybe you don't need to do, called Choosing Wisely. And it's a start. It's not really exactly what you're asking for. You're asking for much more targeted. I have this symptom. What tests do I need? And those materials don't quite exist. We're hoping to create some of that as part of the website that we're creating for at least common complaints. But we need more materials that can help patients become informed about what tests they need. One group of patients that get enormous amounts of imaging are patients who have cancer. And we do enormous surveillance and follow-up and more follow-up. And it's an area where everyone agrees we're doing too much, but we need to have more concrete regimens for how much is the right amount to do. So the question is about how to make decisions about not just CT scan, but other imaging tests, x-rays and dental x-rays and when they're needed. I think every time you're planning to get an x-ray or someone suggests you get imaging, you want to talk to them about it. It's not so much a trust issue, it's a matter of a communication issue. So you want to talk to your provider about why they're getting that information and in some ways negotiate. So if you fall down and your arm's at a funny angle and you're going to the emergency department and you can't move it, that seems like a good time to probably go along with the x-ray. Right? It hurts. It looks like it's broken. They think it's broken. I think a lot of harm can come from fighting back and saying, no, I don't want this x-ray. Medical imaging is very important, and you want to talk to your doctor. On the other hand, if you have sort of a vague belly pain that you've had for 4 years, I wouldn't go to my doctor and say, I really want a CT to see what it is. Right? You sort of want to go to your doctor, and if your doctor says, why don't we get a CT? You might say, well, tell me what you think it could be. Could we start with an ultrasound? You know, it's sort of a discussion. whenever they're ordering imaging. The same way as anytime you get a new prescription for a medication, you wouldn't consider taking it if you didn't know why you were taking it. You wouldn't take a new drug unless you knew what problem it was supposed to fix, what it was supposed to help you with, right? I mean, at least that's my view on new medications. And you just have to look at imaging the same way. Why do you want this? How is it going to help me? What information do you think it's going to give? And that's sort of the approach that I would take. The question is, when you move around from one facility to the next, it's not easy to access your images, and providers often want to repeat examinations. I think that's a very real problem. It would suggest to me moving around comes with some loss of information that really you shouldn't be moving around so quickly unless you're doing it for a reason. And if you're doing it for a reason, then you should get your imaging exams and bring them with you. That's certainly what I do. And I do it for dentists, x-rays as well. Yeah, I mean, they're yours. They belong to you, and you should bring them around. Now, in the radiology community, we're working very hard on this issue to share images. It's an issue that we all know is very important. There's no reason to repeat a study that you had yesterday. You rather want to bring it with you. But it's a real issue. And so I think for something like mammography, where it's very clear you want the old exams, I would strongly discourage moving around each time you have a mammogram without having access to the old images. You're not adding value by doing that. You're hurting yourself by doing that. And I think it's the case for all of the exams that we do. So the question is if I'm working with Kaiser. I think of the 4 large projects I now have going on, 3 of them are in collaboration with different Kaisers. So I'm a very big fan of the healthcare system and an even bigger fan of the data that they're able to collect within their integrated healthcare system model. So I'm currently participating in a project with Southern California Kaiser, with Northern California Kaiser, Kaiser Northwest, Kaiser Hawaii, and Kaiser Georgia on different projects. I also have projects with Geisinger Health, which is another integrated healthcare system, Marshfield Clinic, and we're collecting data from Ottawa, Canada, which is not an integrated healthcare system. It's just a healthcare provider for the entire province and have extraordinary data similar to the Kaiser model. So yes, I collaborate on many of my projects with collaborators at Kaisers.
Thank you.